Thank you, Anuna. That was a very generous introduction. I'm Dr. Preethy, and as Anuna said, I have taught a lot of names I can see here have gone through our department, and I must tell all of you, I'm really glad to be here, and all of you are very fondly remembered. And especially if you remember my firings, I'm really glad, because that's the whole point. You should remember whatever mistakes you made. And I hope today also we'll be able to have a session that is useful. One thing I would like to say in the beginning itself is Sameena had actually come to me with this case early on. So we've literally erased all the errors and blemishes that could have occurred when she would have, actually presented without this practice. And actually, I would have loved to have her present the case in that manner, so that you would realize what are the roadblocks that you run into when you present it during the exam. Now, this has almost been vetted, so there is very low chance of her making a mistake. She has been practicing so diligently for the past few days that I'm sure there'll not be any mistakes. But I'll try to contribute with some questions on my part, and if there are any doubts, please do extend those doubts to me so that I can, try to contribute. I think we can go to the case, right, Anuna? Yes, thank you once again for inviting me. Yeah.
Thanks, ma'am. Thank you, ma'am. Dr. Sameena, you may start the session.
Very good evening to all. I'm Dr. Sameena, final year DNB resident at Lourdes Hospital. Going to my case.
And Dr. Sameena, make sure that you unmute yourself before speaking.
Good evening all. Am I audible?
Yes, you are. Yes, you are.
Is the slides are visible?
Yes, Sameena, I think your slide is visible.
My child is Master Ivy, 2.5-year-old boy coming from YP, first born child out of non-consanguineous marriage, belonging to lower middle class family, and mother is the informant, and information is reliable. The date of examination on 27 December 2022 and date of examination on 29 December 2022. He is presented with fever for last 3 days.
Sameena, am I allowed to interrupt you?
Okay, ma'am.
Can you tell me the importance of whatever you said in the previous slide? Just quickly go through the importance of each and every point you said in the first slide. First is the name. It's an identity, right? The second is the age. Yes, what is important? Yeah, age. So what is the importance of knowing the age of a child?
To assess his growth, development.
Yes.
And nutrition.
Yes. And there are age-specific diseases, right? Certain diseases present at certain age, right? Then coming from YP, does it have an importance? Place?
It's a coastal area. There will be a lot of insects.
Yes.
And waterborne diseases are more common.
Right. So the place a person comes from, there can be certain diseases localized to that place. That is very important. What about the next one?
He's a firstborn child out of non-consanguineous firstborn child.
Yes. What is the importance of all that?
Is a neglected child can be presented with malnutrition and other.
Okay.
And history and development of siblings can be is important if it's second or third order child.
Yes. Yes, when you are advising, giving genetic advice for a certain disorder, the order of birth is very important, and consanguinity, that is another important point here. belonging to a lower middle class family, what importance does that have?
Nutrition and education status and awareness will be less in low middle class family, and their surroundings and their will be more prone to infections.
Okay. And what is the importance of the informant? Can you quickly tell me the importance of the informant? What should the what kind of person should be the informant, and what is the relevance of that?
The informant should be staying with the child and should know all details of the child, and she should be the caregiver of the child, and then only she can give the reliable history.
Okay. Now I'll not interrupt you till you finish your history taking. Carry on.
I presented with fever for last 3 days and cough for last 1 day. Coming to the history of presenting complaints, the child is a diagnosed case of development delay and seizure disorder. Now, child developed a high-grade fever 3 days ago, not subsiding with antipyretics, and fever spike was more towards evening. Child was very tired during interfebrile period and refused to take usual feeds. The cough started on 3rd day of fever, which was wet and more lying down, and sputum was not foul-smelling, not blood-stained, and not associated with post-acid vomiting. There is no history of aspiration recently, no history of noisy breathing, fast breathing, or breathing difficulty. There is no history of rhinitis, rash over body, nasal regurgitation, redness of eye, incessant cry or abdominal pain, no history of abdominal pain or diarrhea, no history of decreased urine output, crying while passing urine, no history of abnormal movements, no history of recent vaccination, contact with person with fever. Baby is febrile. After admission, baby is febrile for last 24 hours and feeding improved after medications and nebulization. Since the child has issues since early neonatal period, I would like to start from the antenatal history. First trimester, first child is a first child of the 24-year-old lady of non-consanguineous marriage who conceived spontaneously after 1 year of married life. The age of father at conception was 28 years. Pregnancy confirmed by UPT after 1 week of missing periods. There is no history of previous abortion. ANC was regular and folate tablets were taken. First dose of TDVAC was taken and no history of hypothyroidism. No history of fever with rash, exposure to radiation or drug intake. No history of bleeding per vagina. USG was done and it was said to be normal. Coming to the history of second trimester, she had a history of fever with cough and she was treated with antipyretics and antibiotics. Quickening felt at 5th month and there was no history of increased or decreased movements. Second dose of TDVAC was taken and iron and calcium tablets were taken. No history suggestive of elevated blood sugar and blood pressure. The anomaly scan was done and it was said to be normal. There was no history of bleeding per vagina or leaking per vagina. History of third trimester. All scans were said to be normal and she appreciated fetal movements well. There was no history of fever, leaking per vagina, false smelling discharge per vagina. No history of suggestive of elevated blood sugar and blood pressure. And she had a sudden onset of abdominal pain and bleeding per vagina at 30 weeks of gestation, following which she had undergone emergency LSCS at 30 weeks of gestation at General Hospital. And baby did not cry soon after birth. And baby was intubated and ventilated. The birth weight of baby was 1.4 kg and there was no history of seizures at birth. Coming to the postnatal history, baby was fed via nasogastric tube on 2nd day onwards and baby was ventilated for 10 days and he was on IV antibiotics till day 14. There was no history of seizures. Baby was started on non-nutritive sucking after 4 weeks and started direct breastfeed gradually. He was shifted to room on 32nd day of life and nasogastric tube was removed as he was on direct breastfeed. Mother was feeding him with the help of syringe as he was unable to suck for long. No history of nasal regurgitation or recurrent aspiration then, and baby was gaining weight during this period. And he was discharged from hospital on 40th day of life and baby weight was 1.8 kg at the time of discharge. And baby had feeding issues after discharge as difficulty to swallow and nasal regurgitation. And NG tube was reinserted on 45th day of life. And he was fed via NG tube till 7 months of age and with the help of syringe till 9 months of age. And he had history of recurrent aspirations while feeding with syringe, but there was no history of hospital admission following aspiration. Coming to the developmental history, and mother noticed that baby was not attaining head control even after 5 months, and baby is not moving lower limb as free as upper limb. Baby was keeping hands as closed fist always, and she also noticed stiffness of lower limbs and difficulty in changing diapers, which she felt as progressively increasing till 1 year of age. He was able to hold neck momentarily at prone position at 10 months. And partial neck control attained at 1 year of age, and he started crawling on abdomen and upper limbs at 15 months of age. And baby is not able to sit or roll over till day. And baby started to open his hands around 6 months of age, and he attained bidextrous approach at 7 months of age and unidextrous approach at 9 months of age. And he started to hold thin plastic sheet or paper at 12 months of age, but he was not able to hold heavy object or soft toys and not able to hold pen or pencil. And baby started cooing at 4 months, and he started making noise when he sees mother at 4 months, and started to call A for his needs at 10 months. And he started to call him at 1 year and mama, papa at 1.5 years. And baby showed started response to sound since birth and started to enjoy rattles and ringing sound of toys at 8 months. And he started to enjoy bright colors at 10 months. And now he follows light to all direction and focus on objects. The social smile attained at 3 months, and he recognized mother at 4 months onwards, and stranger anxiety is not attained. He smiles at sibling who was born at 2 months back, and he was able to perceive touch, pain, temperature, and he responds by crying. There was history of pooling of saliva in mouth, no history of abnormal movement of lip, tongue, no history of deviation of angle of mouth, no history of, but there is history of inconsolable cry occasionally, and history of aggressive behavior when he was fed by someone other than mother. Bowel and bladder control is not attained, and he was on this diaper since birth. To hydrate fever with 6 months back, 2 years, and he generalized abdominal of 15 minutes associated with rolling of saliva, rolling of eyes, and tongue bite 2nd day of fever. He was admitted and started on anti-epileptic since, and he had a breakthrough seizure 1 month back without any fever or drug before. The episode lasted for 5 minutes with focal movements of left upper limb and uprolling of eyes, and he was hospitalized for 1 week, and he had multiple episodes of seizure on 2nd and 3rd day of admission. There is no history of regression of milestones after seizure episode, no history of any vaccine preventable disease.
Sameena, I'd like to interrupt you at this stage. Now you've gone through the history, and you have just take the slides back from the beginning of the history. Okay. Can you take it back? Yeah. Because I want to ask you questions related to this. So, shall we start?
Yes. Sure.
Yeah, so your presenting complaints were somewhat related to the respiratory system, right? Because the child presented in an acute manner with these symptoms. And while you continued to talk to the mother, you realized that the child has a more significant problem, which started probably much earlier, probably from his birth onwards. And which is why you chose to move to the more severe complaints after the presenting complaints. You can do this in either ways. You can either start initially from birth itself, or you present the acute symptoms first and then go on to the past history from birth onwards, as you described, and then go on to the developmental part, because obviously the child has some developmental issues which also have to be addressed. So I'll not just move the slides from the respiratory system to the CNS, because respiratory, I think we'll discuss the CNS part more today. Just go to the, yeah. So that starts, obviously, any CNS disorder which is of long standing usually starts from antenatal history. And can you tell me the any issues here? I think, is there any issue that you can point out here in her antenatal history, which is of relevance to this case?
He had only the mother had history of sudden onset abdominal pain and bleeding PV at 30 weeks of gestation.
Just take the previous slide.
And she had a fever with cough at second trimester, but it's
yes.
not.
Would you say it is not significant?
As it is in second trimester, it is not significant.
I would say it is significant. Why? It is significant because now if you are going to deal with any case of developmental disorder, and most often the case that we come across is disorder from birth is usually a case of cerebral palsy. In any case of cerebral palsy, a history of a mother having had a febrile episode at any time in pregnancy and having taken antipyretics is significant. So it is not that because it is not in the first trimester, so it is not a teratogenic exposure, so it is not significant. It's not like that. Actually, chorioamnionitis, any fever, any antibiotics for any reason does have its impact on a developing child, especially if we are discussing a case where there is developmental delay. So that is one thing that I would like to point out. So because it was a second trimester, you just cannot ignore it. I think the rest goes okay till the 7th month, right? Just take it to the next slide. 30 weeks. Okay, 30 weeks. So sudden onset of abdominal pain and the baby was delivered at 30 weeks, which means the baby was preterm. And again, when we are discussing developmental delay and neurological issues, being a preterm places the baby at a much more vulnerable situation than a term baby. Okay, so those are the two things that are that need to be noted in this. Now take to the next slide. And see, it was an emergency LSCS. Again, when a baby goes through the trauma of a normal vaginal delivery, a lot of stressful factors have already affected the baby, and they're likely to do better. I mean, they come out from an emergency LSCS. Obviously, the respiratory system and all will take some time to adapt. And I think the baby was intubated and ventilated, and it didn't cry also after birth. So here there are few significant things. One, it's an emergency LSCS. Obviously, at 30 weeks, that would be what would be done. And the baby did not cry. That is again significant. And the child was intubated and ventilated. Baby's weight. What do you think about the weight, Sameena? Is it okay for the gestational age? You need a chart, right? Okay. And there were no seizures at birth. So, which somewhat tells you that probably the child was not that bad neurologically at birth, is it? Okay, no seizures. If there were seizures at birth, that would add significantly to the insult that already the baby has had antepartum and intrapartum. If there are seizures at birth, that would indicate a very bad history neurologically. Just go to the next slide. Next slide. Yeah. Now tell me, what are the significant things in this history from that is the postnatal period? Tell me all the significant things that have a bearing on the case that you are presenting.
And he
significant things.
Ventilated for.
Okay.
He was ventilated for 10 days and was on antibiotic for 14 days. And
Yes.
he was on nasogastric tube.
When a baby is on antibiotic for 14 days, what does that tell you?
Maybe sepsis, early onset sepsis, and meningitis could be there.
Yes. And then after that, what is significant? Next history, what is significant that you see in the slide?
History of nasal regurgitation was there, and he was on nasogastric tube, feed via nasogastric tube.
There is no, you have not mentioned nasal. You have actually said there is no nasal regurgitation till he was discharged from the hospital. If I remember, the next slide says there was no nasal regurgitation. But the very point that he was on an NG tube suggests that there must have been a problem with normal feeding, right?
Yes.
So just take it to the previous slide. Previous slide. Yeah.
32nd,
So
32nd day, nasogastric.
32nd day. That 30-weeker coming to the room on the 32nd day of life, 14 days antibiotics is already over and still not back into the room. And it's the 32nd day of life that the baby shifted to the mother's side. And at that time also has a nasogastric tube in situ, means there has been some issues with his feeding and growth, which is why antibiotic is over. So that part is over. So some issues with this, something is impeding his growth and feeding. And which is why there was a delay in moving him to the mother's side. And then again, after he was handed over to the mother, how was she feeding him?
She was feeding with the help of a syringe.
Yes.
And most of the time, nursing staff was with them to help the feeding.
What is that? How is a baby supposed to feed if he's all right? Even preterms who don't have other issues, over time, do we put them to the breast?
No, ma'am. First, we try with the palliative, then direct breastfeed. Started gradually to the direct breastfeed.
It was started, right?
Yeah, yes, ma'am. She was.
Okay, go to the next slide. Go to the next slide. So, till what age did he need a nasogastric tube?
Till 7 months, ma'am.
What does that tell you?
She had the baby had feeding issues till 7 months. Sucking and swallowing reflex was not well established, and maybe some issues swallowing oropharyngeal or pharyngeal phases of swallowing.
Sucking and swallowing is in the initial months. Later on, the baby can actually doesn't really. The baby started on other weaning foods and all from 6 months onwards. So by 7 months of age, actually, you would expect something put into his mouth should be if not chewed, at least it should be rotated around in the mouth and swallowed. Something is wrong in that process, which is why the baby has a nasogastric tube, right?
Yes, ma'am.
Okay. Okay, I think we'll move on. Next slide. We'll move quickly, otherwise it's going to take a long time. Next slide. Okay, can you quickly tell me what are the problems here? What are the ages at which they are supposed to do all these things?
Baby biodextrous approach at 4 months and unidextrous approach at 6 months, and immature.
So, yes.
Grasp at 9 months phase and mature grasp up to 1 year of age.
What about sitting and rolling over?
I'm sitting without with support with 6 months, and with sitting without support at 8 months.
Sitting comes before or rolling comes before? Rolling should be put before sitting.
Rolling, sitting without support at 6 months, sitting with support at 8 months, rolling at 5 months.
Yes.
Rolling over at 5 months now.
Next slide. So, Sameena, why have you put all these things separately? That is, the baby's rolling over and his. Why have you entered cooing and all in a separate slide and all these in separate slides?
I described as different domains. First, motor domain, then gross motor, fine motor, then language and social language, and put it as different domains.
Yes.
As it is a case of development delay.
Yes, grossly we have 4 domains, and according to DDST, there are certain there are certain sections which say there can be up to 7 domains, but here we will consider it mainly as 4 domains: gross motor, fine motor, language, and
language, social.
Okay, so which is why you put each history as separate, right? So, and we call them the red flag signs. For each domain, the red flag signs have to be. So when you learn, DDST is one of the reliable developmental tools that we use, Denver development. But that's a very complicated. It has a huge number of areas. But if you take Trivandrum developmental screening test, TDSC, that has a fewer number of this one. So you can you can take a few major motor, not just motor, each domain, you take the major milestones and set it as a red flags and see the red flag signs at which age, what is supposed to happen. And then you can, adjust your history according to that, because remembering each milestone may not be, if you're able to remember a lot of milestones, that is fine. But the problem is you may remember the milestones at which age it occurs, but the mother at 2 years may not remember every milestone that the baby had. So it is important to select a few milestones which the mother can easily remember and then ask questions according to that. Pertaining to each domain. Each domain has to be separated and the major milestones have to be asked to the mother. Okay, we'll move to the next ones. This is about social. Yes. So the developmental history gets over here, right?
Yes.
Okay. When once the developmental history is over, what is your inference from the developmental history about the condition of the child right now developmentally?
There is significant development delay inside motor, social, and language.
Gross motor, fine motor, social, language, everything is delayed, right?
Everything
so
is
delayed. Would you like to give a term to it?
Global development delay.
Kind of. From the history, now you know that there is a global, when more than 2 domains are involved, you call it a global delay. Okay. So, and now what are the other questions apart from these major domains? What are the other questions that you should ask? And I hope you have asked here. Just get me the next slide, please. Next slide. Sameena, next slide. Okay, before that, so the previous slide, now you have mentioned about abnormal movements. We'll come to that later. Inconsolable cry, aggressive behavior. Now, what is the significance of? I think you've missed out one. Or I would have appreciated it better if you had also mentioned some history about his vision and hearing also. Can that be affected in neurological deficits?
Yes, ma'am.
I think you've covered. You've covered.
Yes, ma'am.
You have said it in one of the previous slides, is it?
Yes, ma'am.
Okay. Then that is fine, because every developmental delay can be associated with certain other related conditions like behavioral issues, seizures, hearing and visual defects. So, the history should encompass not just the 4 domains, but also these other associated features that are seen with developmental delay. Okay, now go to the next one. Next. Go to the past history now. Next. Now, take that slide, past history. And there is a mention of an episode of seizure, right?
Seizure.
So what do you think is this what kind of seizure is this?
He had first episode of seizure at 2 years of age without any previous history, and it was during the COVID infection associated with fever. But the seizure was appeared on 2nd day of fever. So could it be a febrile seizure? Could it be a febrile seizure, or is it? Do you think it is related to the primary neurological issue? It could be related to primary neurological issue. On 2nd day of fever, and he had breakthrough seizures also. Even on anti-epileptic drugs, he had breakthrough seizures without any history of fever or drug default. And that episode was lasted for more days, and it was on 2nd and 3rd day of admission also with anti-epileptic drugs. So that history literally rules out a febrile seizure, because till now he had never had a seizure, right? This is the first episode, right? First episode. So this seizure, whether it is a febrile seizure or not, it is very clear from the history. This is not a febrile seizure. It is associated with the neurological disorder, and hence, whenever you have a seizure associated with a developmental delay, it portends a bad sign for the prognostication. That is, when you have seizures, and especially ones where it is not controlled with one anticonvulsant, that means that the child is likely to have more seizures, and the
general condition is likely to worsen. Whatever neurological condition the child has, that is likely to worsen over in future. Okay, next one. Next slide. Yeah. Okay, he had regular diet history. Yeah.
He was put to breast on 14th day of life, and he was on breast milk and formula milk via nasogastric tube. Complementary feed started with ragi at 6th month, and he is able to take semi-solid food only and is not sharing family diet and no history of food allergy.
Okay.
And there is calorie.
Next one.
Observed calorie intake was 866 kilocalories and expected was 1240 kilocalories. There was a deficiency of 374 kilocalorie and protein required was 22 gram and he is taking 90 grams per day. There is a deficiency of 3 grams of protein per day. Coming to the immunization.
Wait, develop dietetic history there. Actually, you are mentioning a deficit there, right? In both the protein and the calorie. Usually, we see that the calorie is deficient, the protein is mostly normal. Now, here there is a deficiency. What do you attribute the deficiency, the significant deficiency in this particular child?
There is the child is not sharing family diet, and there is diet is deficient of green leafy vegetables and other vegetables.
Has it got anything to do with the condition that is there?
Second, as malnutrition can worsen the development of the child.
So if you have an issue with swallowing and all, will the intake be sufficient? Can the mother force feed a baby who cannot swallow?
No.
And is there a limit to what you can give through the nasogastric tube? Especially if the child is regurgitating very often. Yes. Okay. That I think that attribute that could the deficit could be attributed to the ongoing condition that the child has, and that he is unable to take food or retain it, both take and retain it. So that you could attribute it to that. Okay. Next slide.
Immunization history. He is fully immunized up to age according to National Immunization Schedule. Last vaccination at 18 months, DPT booster and MR2 vaccine and OPV booster was taken, and BCG scar present. Optional vaccines are not taken.
Fairly well immunized, right, for his age?
Yes,
and condition? Yes. Okay, next.
Coming to the family history. Was a non-consanguineous marriage, history of seizure disorder for maternal grandfather and paternal grandmother, and no history of mental retardation in family, no history of stillbirth, IUD, anomaly in family, no history of tuberculosis disorder in family.
I'm really glad that you have drawn the pedigree chart, because in any case where there is a neurological issue, even any other, in fact, in any other significant illness, which is not of an acute nature, a pedigree chart is a must. Only then we can know whether there is some inherited mode of inheritance that is involved in this particular condition. Because we don't know as of now what is the exact condition. So is there any genetic factor that could have influenced this? Now here there is a genetic factor. Actually, both the grandparents seem to have, both sides, right? Both sides have seizure disorder. So he's a candidate to have significant genes transferred which can cause seizure disorder in him. So whether the neurological insult that the child had created the seizures, or whether the genetic problem that the genes that have been transmitted contributed to the seizure, we don't know. So when we have such a presentation where both genes and the circumstances involved, say preterm birth, in that case, what I want to tell you is you should keep metabolic lesions also in mind, not just the circumstantial thing as a preterm or preterm delivery or sepsis. You should think beyond that about metabolic disorders also. Okay, a good thing that you put up a pedigree chart, which is a must when you have a chronic disorder. Next one.
Socioeconomic history.
I think we'll quickly go through that. Just skip it. Okay, you have mentioned, I think we can all see this. She has got it perfectly here. Okay, now you are going to summarize the history, right?
Yes, sir.
Yes, just summarize the history.
2.5-year-old boy, firstborn out of non-consanguineous marriage belonging to lower middle class family and delivered at 30 weeks of gestation via emergency LCS due to abdominal pain and bleeding PV with a birth weight of 1.4 kg, not cried soon after birth. He was ventilated for 10 days and due to respiratory distress and IV antibiotics for 14 days. NICU care for 32 days, started on direct breastfeed on 14th day of life. An history of recurrent nasal regurgitation, was on nasogastric feed till 7 months with an inadequate protein and calorie development delay in all domains. Developmental age around 4 months at present, fully immunized for AIDS, had COVID infection at 2 years of age and had recurrent seizures since then, and he was on anti-epileptic drugs, now presented with high-grade fever since 3 days and wet cough since 1 day with no breathing difficulty.
So what are the possible systems that you're dealing with here? How will you approach your examination? We can't hear you properly. Sameena, if you would correct your microphone, is there something wrong with your connection? Okay, just come. Yeah.
Excuse me, Doctor, please off your video. That will improve the network. Please off your video.
Yes, Sameena. How would you approach? I'll also switch off my, yeah. How will you approach? Now you know the history. How will you approach? You're going to examine the child. What are you thinking? How should you start?
The child is having development delay and
yes,
child is calorie intake is low. And there could be PM protein energy malnutrition will be there. I expect wasting and stunting and examination of respiratory system. Then examination of CNS system for if there are any hypotonia or hypertonia and reflexes.
Is that it? So you want to examine for diet, for any problems with growth and development in CNS, yes, and respiratory system, right?
Yes.
Yes. You think the CVS is the cardiovascular system is not involved in this case? Are you sure? Can you be sure that the cardiovascular system is not involved in this case?
As the child has feeding issues, it can be due to cardiovascular.
So whenever you have a case where there are respiratory symptoms, it would always be safe to examine the cardiovascular system also in detail. So you have 3 systems that need to be examined in detail. Probably the least priority can be given to the gastrointestinal system. But here I would like to say is, since there is the pedigree chart is throwing up some things, and the child also has a long-standing problem, you should actually examine the child thoroughly in all systems, because this could be part of a syndrome. You can't, what makes you say it's not part of a syndrome, or there can't be any involvement of the other organs? So examine every system properly. That's what I'd like to say in this case, because there is the pedigree chart is putting things up. So which is why you should look for syndromic things. You should look for developmental issues which are associated with problems in other organs also. So all systems have to be examined properly. Okay, now just go to the examination quickly.
Coming to the general examination, baby is lying comfortably in mother's lap in supine position with hands by side, legs extended and crossing over the midline. Head was tilted to the right side and baby is alert and saliva is drooling from mouth. He is ill-built and poorly nourished. No signs of respiratory distress and IV cannula is on right hand. Vitals: pulse 110 per minute, regular rhythm, normal volume and character. All peripheral pulses are equally and bilaterally palpable. No radiofemoral delay. Temperature was 37 degrees Celsius at axilla. Respiratory rate 30 per minute, abdomen thoracic. Capillary filling time was less than 3 seconds. Blood pressure 80 mm mercury in supine position. Head appears to be small age. Anterior fontanelle closed. No overriding of sutures. Hair normal. No alopecia. Face no deviation of angle of mouth. Drooling of saliva present. Eyes no skin ptosis. No corneal opacity. Fundus is not examined. Ears normal in position. Nose no discharge. No nasal flaring. Oral cavity, good oral hygiene. Teeth present, normal. No cleft lip or cleft palate. Lymph nodes palpable. Chest shape normal. No chest retraction. Upper limb normal. No polydactyly, syndactyly. No cortical thumb or constant fisting of hands. Normal shape. No visible peristalsis. Lower limb was spastic, atrophied, answering present on both limbs. External genitalia, normal male genitalia, bilateral were palpable. Spine normal, no tuft of hair. Skin, no bed sores, no neurocutaneous markers, normal skin turgor. No signs of vitamin A deficiency. Coming to the anthropometry, weight was 7.5 kg and it was less than 3 deviation. And length was 30 centimeter, also less than 3 standard deviation. And there is severe stunting according to the WHO group chart. Weight for height was observed was 7.5 kg and it was also less than 2 standard deviation, -2 standard deviation. It was moderate wasting. Head circumference was 44 centimeter. Expected was 49 centimeter. It is below 3 standard deviation. And there is microcephaly. Mid-upper circumference was 11 centimeter and it is also less than 3rd centile, denotes PM. Coming to the developmental assessment, on pull to sit, the baby had head lag and the head was hot.
Sameena, I'd like to interrupt you before you go to the developmental assessment. So the initial, just go to the examination slides quickly from the beginning. Okay, this is the initial impression you get of the child, right? The lie of the positioning of the child. What about alertness? The child looks alert, right? And you have said the child is ill-built and poorly nourished. No signs of respiratory distress because you had a history of respiratory illness. And there's an IV cannula on the right hand, which is so. From this, what do you infer? That it's a child with some tone or power issues and with saliva drooling from the mouth. Is it normal for this age, 2 years? Does a 2-year-old child have saliva constantly drooling from the mouth? No. And no. And there are no signs of respiratory distress, which means the acute condition has been, it's almost okay now, right?
Yes, ma'am.
That is the inference you get from this slide. Just go to the next slide. Next slide.
Yes, ma'am.
Yeah. So what I'd like to mention here is that there are 4 things before we start developmental examination. First is the general look or the general assessment that we do by seeing or touching the patient. The general assessment including the posture of the patient, the level of alertness, whether the child is sleeping or whatever, and any significant things that can come to. Now, there is one thing that I would have expected in a chronic neurologically ill child, that was dysmorphism. So dysmorphism, I don't see any mention of dysmorphism in the first slide, which should have come if the child were dysmorphic. So are you trying to say that the child is not dysmorphic?
No, dysmorphism, ma'am. The head appears to be small for the age.
Okay. So you're saying, right. So there is no dysmorphism in the child. Well, you see, the dysmorphism is usually an abnormality in the facial contours or the relative positioning of the different organs or any obvious congenital anomaly. So when a neurological syndrome is associated with dysmorphism, it usually points to a congenital lesion, a chromosomal defect, or something of that sort, not an acute defect attained during pre or intrapartum time. So, absence of dysmorphism itself tells you that this is less likely to be, it's just one of the indicators to say that it's less likely to be a congenital or genetic disorder. Okay. Now, so these the four sections that have to be mentioned are the general examination. The second one you mentioned was the vitals. Now we have to. I think some places I have seen the order being the next one being anthropometry. Now it is fine as long as all these four things are mentioned. That is, you can mention anthropometry if you want. Actually, some of the books put anthropometry as next after general examination. You can go that in that order. Or here you have mentioned vital signs, and here everything is okay. Next slide is anthropometry, isn't it? Next slide. Yes. So the next one you're mentioning is anthropometry. Just take it to that slide. Do we have anything significant there? Yes. So you have mentioned a head which is small and ruling, right? And
yes.
And anthropometric is throwing up a lot of findings. That is, you have the first one. What does that tell you? Less than 3 standard deviations in a child. What does that tell you? What comes to your mind when you see a child who is growing, whose growth or whose weight gain is less than 3 standard deviations for the age? What one or what? Yes, it is malnutrition. I would call it a failure to thrive. Actually, if once the it is on its way to a failure to thrive, because once you cross 2 centiles, there is more likelihood of failure to thrive. Okay, so we have to watch for a failure to thrive in this child. And if the child has following visits with us, how would you monitor for failure to thrive? What will you plot? What will you plot for this child? That's my question.
Serial weight gain.
What is it called? It's a
growth chart.
Growth chart, yeah. Yeah, it's a growth chart. And if the growth chart, you see the growth falling by 2 standard deviations in your subsequent visits, that means the child it's falling off the growth chart from the road to health, it is falling down. Okay, now the length also shows severe stunting. There is moderate wasting, there is microcephaly and severe PEM. From the stunting and the PEM, what do you infer? Is this an acute or chronic or acute on chronic? What would you think is it? You say anything?
Acute on chronic malnutrition.
Yeah, okay. Chronic malnutrition, probably there's an acute component to it. And there is wasting and there is microcephaly, which could be due to the neurological issue. Okay, so yeah, so there is severe PM. We'll go to the next slide.
Developmental assessment, ma'am.
Yes, next one. Yes, developmental assessment. Next one is head to foot, right? Okay, head to foot is over. So there are 4 things: are general examination, vitals, or anthropometry, whichever order you follow. Vitals, anthropometry, and head to foot examination. Okay, you put developmental assessment before that, is it?
Over, ma'am.
Okay. Carry on. I'll interrupt you after some time.
Developmental assessment, on full to sit, there was head lag, and on ventral suspension, head hold momentarily at the level of body. And on vertical suspension, ring was present on both legs. Coming to the developmental domain, the last gross motor mild was partial control. The developmental quotient for that was 30%. The last attained was immature pincergram. The corresponding developmental quotient was 30%. Coming to the language, the development quotient was 30%. Last milestone was bisyllables. Social domain, The last milestone was recognized mother. Development was 13%.
So here we are seeing mention of this is the quotient. The percentages that she has mentioned are the quotient. So you can either present the quotient as development as a part of developmental assessment, or combine the developmental history with assessment and put up an entire quotient. I mean, for each domain, you can put together the developmental history of that particular domain with the assessment results that you have. See, the problem with assessment is that you cannot, the child who's lying, who's sick and on an IV cannula, you can't make the child climb stairs one step at a time. So there is a limitation to the amount of developmental assessment that you can do. So you can combine it with history for each domain and then put up a developmental quotient. If you are unable to do say the child is is not well, totally unwell, you may not be able to do much developmental assessment, in which case you will have to rely on history, and you can get the developmental quotient from a reliable history from the mother of the red flag signs I mentioned. Okay, so developmental quotient for each, how do you reach a developmental quotient, or how do you calculate it? The developmental quotient for each domain has to be calculated. How do you do it? You have to say gross motor. Now you take gross motor and see and get the history from what developmental milestone has the child attained completely, say rolling over. So you roll over from back to prone position, and then from prone to supine position. The complete rollover, it should be completed by around 6 months. So completed developmental milestone of that particular domain. When did the child reach? Suppose the child rolled over at 1.5 years. So 1.5 years is the time that the child has attained that milestone. But when should he have actually attained it? Were it a normal child, he should have attained it at around 6 months. So what is the developmental quotient? You divide the 6 by the time that the child has attained and see what percentage has he attained. I mean, what is compared to the normal that he should have attained, by what percentage has he attained that with respect to his age? For each domain, the developmental quotient should be calculated like this, by taking a completed developmental milestone and comparing it with the age that he has attained now, and comparing it with when it actually should have been attained. So for each one, just show me that slide. Anuna, is it okay if we overstep the time, because the CP or developmental take some time? Is it okay if we carry on for another 15-20 minutes?
Yes, ma'am. Yes, ma'am.
Okay. So the developmental, this one, you have to mention the quotients in each domain. Okay. And could you actually examine the hearing and the visual, this one? Sameena, could you examine hearing and visual milestones also?
Following like direction and
okay. That's a very difficult thing to do. Basically, you can just see whether the child can hear and whether the child can see by seeing whether it's following bright objects or the mother's face. Beyond that is not, it's not possible to examine in the exam. So what are the tools that we have to examine when such a child comes? What can we further do other than our clinical examination? It has its limitations. What can you refer the child for?
Vision and hearing.
Yes. The test, and there is something called the STICA test, which is the Mary Sheridan test for young and retardates. These are special tests for hearing and vision, which are done especially for the very young, who can't take instructions and follow them. Young and retardates. Those tests will help us assess the hearing and developmental milestones and the hearing and visual, not hearing, the visual and other this one. So. So some tests will have to be, our examination will give us a limited idea. Beyond that, we have to do these things. Okay, we'll go to the next one.
Examination of respiratory system. Respiratory rate was 30 per minute, abdominal thoracic. Examination of upper respiratory tract, nose normal, no discharge, no flaring of alanaceae. Oral cavity, good oral hygiene, no dental caries. lips, gum, normal, palate, normal, throat, normal. Examination of lower respiratory inspection, trachea appears to be central. No use of axillary muscles of respiration, no chest wall deformity. Chest movements appears to be symmetrical, no intercostal or supraclavicular retractions. Apex beat not visible. On palpation, trachea central, apex at fourth left intercostal space at midclavicular line. Chest movements were symmetrical and transverse diameter was posterior diameter. Percussion was not done. Auscultation, normal vesicular, breath sound, head on all auscultatory areas. There was no added sounds.
Sameena, why did you give precedence to the respiratory system when you have so many problems with the CNS? What makes you mention the respiratory system before the CNS?
The currently child presented with cough and fever, so I examined the respiratory system first, as the acute problem should be addressed first.
See, we are learning how to take a case so that we are able to address the problems that the child has. And whenever a child has an acute problem, especially one which could be life-threatening, our focus is to be on that. Something he has had since birth, we are not going to do much immediately. So the priority, while CNS may be the issue you may have many findings and there might be significant things to look for. When you're looking at the child, you have to solve his life-threatening or acute issues first, which is why the respiratory system gets precedence here. And only after that, you will go to the next system is?
CNS, central nervous system.
Yes.
Examination of CNS, higher mental function, height, not wanting to call. Examination of cranial nerves. First nerve could not be examined. Second nerve, pupillary reflex normal and Meniere's reflex present. Direct and indirect type. Fifth and conjunctival reflex normal. Seventh nerve, no deviation of angular symmetry during trying. Labial fold present. Eighth nerve of the sound. Cooling of secretion. Gag reflex tested. 11th nerve, you head to both sides to not be tested. An examination of sensory system, he was able to perceive.
Sameena, let me interrupt you there. Did you do the corneal reflex?
Yes, ma'am.
How did you do it?
With cotton. With cotton, I touched on the limbus of the eye and look for the response of the.
Did you actually do it?
Yes, ma'am.
Yes, you did it. So corneal reflex and conjunctival is even okay. Corneal reflex, I'm not so much in for a child being subjected to a corneal reflex because the cornea, once injured, it will go in for opacification. That's not the best place to do. The child, especially in a child with disorders who is not going to stay quiet for your examination, I think you can skip the corneal reflex. So here what I would like to say is when you examine the cranial nerves, she has mentioned a lot of things that are present. What you can see by visualization, you put that up, that is present, say no squint, no ptosis, all that is fine. But when you really have to touch the patient, please see, our priority is the child's well-being, not our findings. Our priority is that there is no harm is done. So if you need to skip an examination like a corneal reflex, you can do that because it's not going to be of much value to your findings. So I would prefer that don't do a corneal reflex in a small child. Conjunctival is even fine, but cornea cannot be injured. There is no scope for injuring a cornea. So, and the others, okay, whatever you can do without harming the child, carry on. Any test that you think can harm the child, you can very safely tell the examiner, because the child was uncooperative, I could not perform this test, and so I have skipped the test. I don't think anyone will penalize you for not doing a test that is very difficult in such a child with so many problems. Rather than doing something and then creating an issue there or injuring the child, The child, once you touch the cornea with it, if your wisp is thicker than it should be, it'll cause so much burnings. It'll water the child, and the child will start yelling, and thereafter you will not be able to examine anything. So better you dispense off with that corneal examination and go to the next one. I hope you got the message. You should not do a test which is not good for the child for that age, especially one that is a child who is uncooperative, and especially one which is not going to give you much information with that particular. Skip it. Say that I have not examined it. Whatever you can do, do. Okay, next. Okay, next. Next, I think you covered this. Next.
Okay. Examination
sensory system. Sensory system. Okay, sensory system.
Able to first, the baby is be able to perceive touch and respond to cold and heat and respond to pain by crying. Examination of motor system. Bulk was reduced bilaterally and symmetrical. Tone, coming to the tone, there was normal tone observed in both upper limbs, and there is hypertonia with spasticity on both lower limbs. Examination of power. The best observed power in upper limb was 3/5 on both sides and 2/5 on lower limbs, both sides. Examination of reflexes. Superficial reflexes, corneal, conjunctival, abdominal, cremasteric reflex were done. Is normal. Palatal and pharyngeal reflexes was not tested. Plantar reflex was extensor bilateral.
What does this information tell you from the reflexes? What are you getting? What is significant here?
Extensor plantar, madam.
Extensor plantar. That tells you that it is
extensor plantar.
What does it tell you? What does it, in one word, what does it tell you? Two words, what does it tell you? What kind of lesion is it? 2-year-old child with extensor plantar bilaterally. What does the child have?
UMN lesion.
Involving?
Pyramidal.
Yes, involving the pyramidal tract and both. Okay.
Both sides. Both sides.
Yeah, both sides. Yeah. Okay. Next.
Deep reflexes. Jaw jerk was absent, and biceps, triceps, supinator reflex was 2+ on both sides, and knee jerk and ankle jerk was exaggerated on both sides, and clonus was absent.
So generally, we can see that the lower limbs are more affected than the upper limbs, right? Here?
Yes, ma'am. Here
yeah.
also
Okay.
lower
Next.
limbs.
Yes. Next.
Coming to the neonatal reflexes, symmetric tonic neck reflex present, and glabellar tap also present. Palm grasp and grasp were negative, and reflexes present.
What information, significant information do you get from this?
Asymmetric tonic neck reflex was present.
So ATNR, when is it supposed to go? When is it supposed to,
When
is it normal? Is it normal to have an ATNR present?
No, ma'am.
When it's supposed to go?
And 5 months. 5 months, so, 5 to 6 months, ma'am. When child starts to roll over.
Yes. So the child can roll over only if the ATNR goes, because if it is in a fencing position, how can the child roll over? When every time you turn, how can the child roll over? So which means the lesions start from there. 4 months onwards, that is still persistent, means the child has not yet, it is not even 4 months old. Okay, next slide.
Cerebellar signs and autonomic nervous system, both cannot be tested.
Yes.
Coming to the examination of GIT, oral cavity, good oral hygiene, lips, gum, teeth, normal, inspection of abdomen, shape normal, umbilicus is central, not distended, no visible peristalsis, visible pulsation, hernial orifice and external genitalia normal. On palpation of abdomen, no local rise of temperature, tenderness is soft and no mass palpable. On auscultation, normal bowel sounds present. Examination was 110 per minute and BP 80/60 millimeter mercury. On inspection, trachea appears to be central, not visible. Recording shape and size normal. On palpation, apex at 4 left intercostal space at midclavicular line. Auscultation S1, S2 head over all areas. There was no murmur.
So is the CVS and GIT normal in this child?
Yes, ma'am.
Okay, so only 2 systems involved. Okay, now just summarize.
2.5-year-old boy. Shall I summarize the history or examination?
Summarize the entire thing from history to examination, one summary. Now, once you have finished examination, you should put everything together. Not separate, not history separate, examination separate. Put everything together.
2.5-year-old boy, first born out of non-consanguineous marriage, belonging to lower middle class family, delivered at 30 weeks of gestation via emergency LSES due to abdominal pain and bleeding per vagina, with a birth weight of 1.4 kg, not cried soon after birth, and was ventilated for 10 days due to respiratory distress and on IV antibiotics for 14 days, NICU care for 32 days, started on direct breastfeed on 14th day of life, history of recurrent nasal regurgitation, was on nasogastric feed till 7 months with inadequate protein and calorie intake, with history of development delay in all domains, developmental age of 4 months at present, fully immunized for AIDS, had COVID infection at 2 years of age and had recurrent seizures since then, and was on anti-epileptic drug, now presented with high-grade fever since 3 days and wet cough since 1 day with no breathing difficulty. On examination, child is conscious, alert, stable. On general examination, there was microcephaly and both limbs with moderate protein energy malnutrition and global development delay. On CNS examination, sensory system appears to be normal and there was hypertonia and hyperreflexia of both lower limbs with bilateral extensor plantar response and all other systemic examination within normal limits.
Function followed by higher mental function is followed by order of CNS examination.
Higher mental function examination of cranial nervous system.
So you had, don't you have findings in the cranial nervous system examination?
There is pooling of secretion.
Yes, yes. So what does it tell you? So where is the cranial nerve findings? Yeah, where are the cranial nerve findings and summarization? Actually, you should have brought up, go in order. I mean, higher mental functions followed by cranial nerves, motor system, sensory system, meningeal, cerebellar science, meningeal science, and in that order. So when you have findings, then better mention that first before saying that the sensory system is normal. You can start with cranial and then higher mental functions if that is relevant, then cranial, then motor, then sensory, and so on. Okay, so now the case is summarized. Now you just tell me your diagnosis, Sameena.
The case of spastic quadriplegia, level 5 disability, global development delay due to prematurity and perinatal asphyxia with seizure disorder and moderate protein energy malnutrition, ARI, no pneumonia, fully immunized up to AIDS.
Okay, you have opted for spastic quadriplegia. Now, if we go through your examination findings, actually the lower limbs are much more involved than the higher limbs. Upper limbs, then why did you go for spastic quadriplegia instead of spastic diplegia, which is more relevant if the lower limbs are more involved?
The child had feeding issues, ma'am. Maybe supranuclear palsy could be there.
Yes, yes. When the child, yes. Yes, when a child has evidence of supranuclear palsy of the oropharyngeal muscles, when a child has level 5 disability, when a child has global developmental delay, it is less likely to be spastic diplegia. It is more likely to be spastic quadriplegia, which is why this is appropriate to say that this is spastic quadriplegia. If the child had nearly normal mentation, or if the child did not have supranuclear palsy, it could have been put in as a spastic diplegia rather than a quadriplegia. And especially with other things like seizures and all, it is when you have when the brain, all domains of the brain are significantly involved, it is better to go in for spastic quadriplegia, where all four limbs are involved. But maybe to some extent there is a difference in the involvement of the upper and the lower limbs. So your diagnosis, I think you're not left out anything, right? Everything is there. Okay, that's the diagnosis is fairly okay. Now, would you like to discuss the condition?
Yes.
Why are you not calling it a metabolic disorder?
There is no history of recurrent vomiting, pain, and on examination, there is no signs of organomegaly, no regression of milestones.
Yes, so there is nothing suggestive of a metabolic disorder here. This seems more like there is some static insult which has with a progressive change in the domains or the milestones, but the insult doesn't seem to be progressive. If the insult is progressive, then you have to keep metabolic disorders also in mind.
Okay.
Yes. So I think the diagnosis is over, and we are fairly clear that this is spastic quadriplegia with global developmental delay and with seizures accompanying PEM, seizure disorder, and fully immunized up to age, presenting with an acute problem, that is acute respiratory infection. And the CP was the cerebral palsy was probably due to, from the history we infer that it was due to prematurity and perinatal asphyxia. Now, is there any other DD that you would like to consider other than metabolic?
Neurodegenerative disease.
Neurodegenerative disorders.
Regression of milestones.
Yes. No regression of milestones. Yes, I think that comes to the very well presented. And I think if I'm asking questions about CP, I think that's more of theory, not about presentation. So I think we can stop here if there are any. Anuna, can we stop the case presentation here and go on with the doubt clearing session?
Yes, ma'am. Yes, ma'am. We have a question in the chat box, ma'am.
Okay.
Can I say the question?
Yes.
Okay. In summary, should we elaborate everything about natal, postnatal history, or can we say possible perinatal asphyxia in the summary itself?
Yeah, it is better to make it short. When we summarize, only the relevant things need to be said. So here, in the natal and postnatal history, there are two things which I found were relevant. One was that the mother had an episode of infection for which she needed antibiotics. And the second was a preterm delivery with a possible perinatal asphyxia because the child did not cry and was on ventilator and needed tube feeding for quite long. So it is better to put those relevant things on. One is infection in the natal period, and two is preterm birth with evidence of perinatal asphyxia. Those 2 points. Don't say the whole thing again.
Okay.
Open to discussion. PGs, kindly ask your questions. Unmute yourself and ask. Please post any questions if you have in the message group. Please post in the chat box. I think
everything is clear, right?
Probably.
Okay, we can presume that, or we could discuss anything if there is anything at some other time.
Sure, ma'am. So we had an extensive discussion about cerebral palsy for that matter right now. I'd like to welcome our FM360 coordinator, Spicewood Kerala, Dr. Vishnu BS, to deliver the vote of thanks.
Thank you, Aruna. This is Dr. Vishnu. First of all, I would like to thank Team Lourdes for coming up with the case presentation for this month of February. And I would like to thank Sameena for coming up with a wonderful case, which should have been very informative for all the participants. And I would like to say we had participants from various, not just from Kerala, we had from Kashmir till Kerala, we had participants attending this session. And thank you, Preethy ma'am, for the wonderful discussion we had. I hope it was very informative for all the PGs and the senior people who have attended this session. And I would also like to thank the senior teachers and the senior family medicine specialists who have turned up for this session, and all the PGs from across the country who have participated in this session. Thank you, everyone. We'll meet again next month.
Thank you all. Thank you.
Thank you, Anuna, and everyone who gave me an opportunity for this. Thank you.